I'm Anthony Johansson. I'm a geriatrician working in the trauma unit in Cardiff. I also run the National Hip Fracture Database, the Fracture Liaison Service Database, and the National Audit of Inpatient Falls for the RCP in London. The audit framework, the National Clinical Audit, that captures the impact of everything we're talking about today. I'd like to introduce Inder Singh, who you may have noticed has put all of this together, and I'm hugely grateful to Inder for today's meeting. Back in 2005, I interviewed Inder for an SHO job in geriatric medicine. We asked him lots, he tells me they were very difficult questions, and we didn't give him the job. We sent him outside, he sat outside, and we brought him back in and gave him a registrar job because he was much too good to be the SHO that he'd applied to be. And he's continued to be much too good for the jobs that he's taken since then. He's currently our National Clinical Lead for Falls and Frailty and works as a geriatrician in an hour in Bevan, fiddling with all sorts of things, and has personal clinical and research experience in all of the topics that we're talking about today. Inder.
Thank you, Anthony. So thank you, everyone. Our agenda is full of prominent speakers from a range of backgrounds with a focus on delivering future liaison services across Wales today. This conference comes at a very important time when all health boards need to reflect on how we provide our services and support our population, particularly the most vulnerable and older adults. We are particularly privileged today to have both Minister for Health and Social Services and also the Chief Executive of the NHS in Wales with us. We thank for their interest and their time today. This is the beginning of a very important conversation. To begin this conversation, I'd like to invite our keynote speaker to the stage, the Minister for Health and Social Services for Wales, Eluned Morgan. Thank you.
Diolch yn fawr. Thank you very much. And sorry to be a little bit late. We've all been a bit distracted. I'm sure you kept up with the news. See my big smile? It is quite extraordinary to be watching the scenes in London, the absolute chaos that's been going on, not just in the past 5 days, but over the past few years. I'm not going to apologize for wandering into politics here, because I think we've all got to recognize that actually that chaos is going to have a consequence. It already has had a consequence. There are people in this country who are now finding it difficult to put food on the table, to heat their homes, and to pay their mortgages. And that's as a result of the chaos that's happening in Westminster. And I'm not going to apologize for that. There will be consequences for each and every one of us. And I'm damn glad she's gone. And I'm really fearful for what's coming next. But whatever comes next, it's not going to be easy. And we're going to have to sweep up the mess here in Wales of those very difficult and stupid decisions that have been made in London. So thank you. You just needed to indulge me because I needed to get that off my chest. I hope you don't mind, but it's quite incredible. 5 prime ministers in 6 years, 4 chancellors in 4 months. I mean, we're a laughing stock around the world. It's not funny anymore. This is a political experiment that has been carried out, and the price is going to be paid by the poorest and the weakest and the most vulnerable in our society. And it's just not funny anymore. So anyway, time for Labour government, but we won't go there yet. Thank you very much. And thank you very much for inviting me to this conference. Dwi eisiau diolch yn fawr i chi gyd am fynych i'r cynhadledd heddiw, y rhai ohonoch chi sydd wedi ymuno wyneb yn wyneb yn y ganolfan yma, a rhai ohonoch chi sy'n mynychu o bell. A mae'n braf gael cymaint o bobl yn rhannu profiadau a'i dealltwriaeth i wella iechyd yr esgyrn yng Nghymru. So thanks very much for attending today's conference. And I think this is being streamed as well. Is that right? Excellent. So thank you to those of you in the room and those who are joining us virtually. And it's going to be a great afternoon, I think, just hearing the insights and experiences of so many people on how we're going to be improving bone health services in Wales. I've been to visits of accident emergency. The chief executive of the NHS has a little small heart attack every time I go without telling them I'm on my way. And it's been really interesting, very interesting, particularly going to the children's wards. And one of the things I'm thinking of doing is banning trampolines. So there's lots of things we can do in, I think, to make sure that we look at prevention, what more we can do. I'm not going to ban trampolines, just so that we're clear, okay? I don't want that as a headline. I don't think I'm going to get any headlines today, but today I think it's an important day in terms of that future journey for bone health in Wales, because society is judged by how we look after the most vulnerable members of our society, which is why I'm so tamping mad at the moment. Experiencing a fracture following a fall can be a life-changing and a life-limiting event that can have lifelong consequences. And we'll all have loved ones potentially at risk of falling and fracturing bones in their later years. So falling and fractures are difficult to stop. But when somebody has been identified as a risk, we must take the initiative to ensure needless repeat fractures are avoided at all costs. And I want us to work together and use every opportunity to ensure those who've been unfortunate to experience a fragility fracture are provided with the tools and the support to improve future outcomes. So osteoporosis is a common and it's a debilitating condition, and there are an estimated 18% of the Welsh population living with it. So having osteoporosis raises the risk of fragility fractures, and 1 in 2 women and 1 in 5 men over the age of 50 are expected to break a bone during their lifetime. In addition to the physical pain, fragility fractures can have a debilitating effect on mental health and also on well-being. People can become afraid to leave their homes once they've experienced a fall, and social isolation becomes an increased concern. So work is needed in a range of areas to support people within our communities. And this focus today is reflecting specifically on secondary care prevention of fractures. But I think as a nation, we'll also need to focus on primary prevention of fractures by increasing public awareness of falls and supporting those in primary and community care. I used to work for an energy company, and you can imagine in an energy company, safety is absolutely critical. And usually the focus, you can imagine, you know, if you're trying to fix a 400 kV line, you know, there are some serious safety issues you need to consider. But the philosophy of safety ran through the whole company. And it was quite a shock to me when I joined the company to find that it was a sackable offence if you were caught 3 times not holding the handrail as you went down the stairs. And that's, you know, I just thought, God, that's pretty harsh. But actually, God, it gets you into a safety zone. And I never go down the stairs now without holding the handrail. And it is those little things, I think, that we've all got to understand, that we've got to get that message out to the public. And certainly, I'm sure many bones have been saved from people taking those small little actions. Now, the Welsh Government recently helped fund Care and Repair and Age Cymru's Falls Awareness Week campaign. I'm really pleased. My mum's just had a little handles put into her home, so hopefully we'll get, we won't be in a situation, because my gosh, I haven't got time to take her to hospital at the moment. But it's really important, I think, that we take time to make sure that we put those prevention measures in place, and Care and Repair are doing a great job. We're really grateful to the National Falls Task Force for their work and support in this area. Now, the objective is to ensure we keep people out of hospitals unless they need to be there. And today you will hear evidence as to why fracture liaison services are a proven method of intervention, which reduces further fractures, helps to keep people safe, and are cost effective for the health service and for wider society. Now, before we can strengthen our direction, we must understand the current landscape. We need to provide adequate support for clinicians to build services within their health boards. And I'm therefore pleased to announce today that the Welsh Government, alongside the National Clinical Lead for Falls and Frailty, Dr. Inder Singh, have initiated a fracture liaison service development and a quality assurance group. Now, this group will be focused on reducing the inequity of the services across Wales. It'll be responsible for assessing the current status of services and reacting to the relevant audit data, holding health boards to account and supporting health boards in their development and their delivery. Now, the creation of this board and the conference today is the accumulation of a consistent and a determined campaign for the relevant services by many clinicians, members of the public and third sector partners, many of whom are here today. And I want to pay tribute to you all for your passion and your commitment. Creating systemic change is never an easy task, and we will require everyone within this room and beyond to support this agenda and to promote the importance of bone health within every health board in Wales. We're privileged to have eminent speakers here today to share their knowledge and perspectives about what we're doing well, where there is scope for improvement, and how best we can develop. They'll be discussing why the same issues appear across numerous geographical areas, and it's important that we use days like today to be a part of that important conversation. We will hear from clinicians involved in providing the services, and importantly, from those affected by not having access currently. Now, the patient voice is key to ensure services are reactive and reflective of the needs of those who rely on them. And I'm pleased we'll be able to hear real-life examples of where improvements have been embedded in practice and are making a real difference for the families where services are available. The Welsh Government is clear in our commitment to supporting all those at risk of falls and fractures. We fund participation within the internationally renowned National Clinical Audit Programme, within which the National Falls and Frailty Audits suite of audits are included. The programme provides us with statistics and an expert narrative, and crucially includes recommendations for our health service to respond to. Now, in January 2020, following unfavourable audit results relating to falls and frailty, the Welsh Government undertook two key actions that have led us to today. First, we initiated the Falls and Fragility Fracture Audit Programme Strategic Group, bringing together key stakeholders from across the service to review the results of audit and to outline how we need to tackle improvements. And following this, we appointed a national clinical lead for falls and frailty, Dr. Inder Singh, to provide clinical leadership and facilitation. And I'm really grateful to Inder and the relevant advisory groups for their work to date. Audit results from across not only Wales, but also England have highlighted how the services for post-fragility fractures is not where it needs to be. We're on a journey to change this. We're also really fortunate to have such engaged third sector partners supporting us with this work. The National Clinical Audit for Fracture Liaison Services is managed by the Royal Osteoporosis Society. Their role is not limited to providing the detail of the current services through their audit reports. Their ongoing support extends to outlining the personal benefits of the service, the financial savings health boards can make, and providing best practice to establish the services where they're needed. And we look forward to hearing from them later in the day. Now, the Chief Executive of the NHS in Wales and the Deputy Chief Medical Officer for Wales will shortly be sharing their perspectives on current service provision, as well as the strategic direction Wales has taken as we look to the future. We're still building our vision for care for older people in Wales, and consider everyone here today as important partners in progressing this work. We know there's work needed, not only in our hospitals, but to consider that community prevention of falls, that public awareness, and providing assurances that those who require anti-osteoporosis therapy receive it. This includes ensuring we have a fracture liaison service that covers everyone in Wales, no matter where you live. Safety and quality of services is everyone's responsibility. I want us to work together to continually improve the outcome for the people of Wales and the wider community at large, driving forward a learning culture and creating the most comprehensive bone health service in the UK. So thema heddiw yw bod diogelwch yn gyfrifoldeb I bawb, a dwi am I ni weithio gyda'n gilydd I wella'r canlyniadau I bob un yng Nghymru, gan sbardino diwylliant cyfiawn sy'n dysgu'n barhaus a chreu'r gwasanaeth mwyaf diogel yma yn y Deyrnas Unedig. Diolch yn fawr iawn I chi gyd. Thank you very much to you all.
Thank you, Minister. The goal of today's event is for the NHS to look at improved methods of treatment and support that benefit all parties. We are delighted you are able to join us today and launch our delivery assurance and the quality group, and look forward to reporting our findings to you and the rest of the colleagues in Welsh Government. We are in esteemed company today, and as we invite our next speaker to the stage, please welcome the Chief Executive of the NHS in Wales, Judith Paget. Thank you.
And Prynhawn da pawb, it's fantastic to be here, and what a great day. Nothing to do with Liz Truss, but to have the first bone health conference in Wales. It's brilliant to see so many people here, but also online joining us as well. So well done to everybody who's managed to get this organised. And I do get asked to speak at things quite often, as the Minister does as well. And I was really keen to be here today, not just because this is a really important topic, and not just because I know Inda really well, but actually I've got my own personal experience with my dad of him falling, fracturing his spine, having fantastic care from his local NHS, both from the ambulance service, from his local hospital, orthopaedic team, but also from those people who look after him when he was discharged from hospital, the Falls Frailty team, who did a fantastic job to help him in his rehabilitation, but also to make sure that he didn't fall again, and the assessments that they did, the care that they gave him, but also then the support that came from the third sector as well, to wrap around them to make sure that he was safe at home and we could support him, was fantastic. So I think it is really important that we focus on bone health. And as I said, I am really so pleased to be here today. I think our reflections are around COVID is that there's been a raft of critical learning that's just shaped and adapted our approach to how health services are delivered. I think we are on a transformation journey. I sometimes don't like using those words, so I almost feel I should apologise for it. But we are indeed on a journey to transform our services. And that transformation journey was set out in A Healthier Wales, which is actually still our long-term plan for health and care in Wales. And every now and again, we bring it out and dust it off. And I know the Minister's been reading it again recently as well. And she will be soon asking me, so what progress have we made, Judith, on making sure that those deliverables have been enacted? And actually, how could we have known in the summer of 2018, when we launched A Healthier Wales, that a global pandemic was on the horizon, that it would test its strengths and weaknesses as a vision for our seamless service? But it very much focused on prevention, community-based care, and only going into hospital when absolutely needed. And I think through the last couple of years, we've seen the transformation already of some of our services edging towards that, but there is so much more to do. I think throughout the COVID response, we made significant progress in that direction. I mean, clearly it was mostly through necessity to try and keep everybody safe. But we did it, and our services changed really swiftly and rapidly to make sure people did feel safe and cared for at home. And a lot of the people in the room today and those listening in joining us on the Teams link will have been involved in changing the way the service is delivered in order to respond rapidly to the changing environment in which we were all working. And now as we move to recover and reset, whatever words you like using in your team, we just need to make sure that we remember what the art of the possible is, because we know we can do this. And this is what we will be doing as we now move forward. I think every service is reflecting on its practices. We've learnt so much. And I think we all know that doing things the way we've always done them is not going to be the way that we need to do them going forward. I think we do collectively see an opportunity to do things differently. And this is why this conference, having you together, sharing your knowledge, skills and expertise, sharing your ideas and sharing your ambition of how you want your services to change is really important. That is part of our transformation process. And for many services, those conversations need to happen. I'm just so pleased that today you've gathered here and those conversations are starting for this. This is really important work. Everybody who's been involved in service development, and I know all of you have, know that change is not easy. Change in services is not easy, but I am really assured to see so many people here. And I know you're here because you recognize that services do need to change and adapt. And we absolutely need to make sure that fragility fractures and repeat fractures are something that we can address and manage and change the way in which our services are delivered. We've all reflected on the experiences of the pandemic, and we talk about it as if it's gone, and we know it hasn't. It's definitely still with us. But I also know how hard the staff worked in the NHS and in our care system and in the third sector to actually respond to the changing context. Clearly now we are about seizing the opportunity to do things different, but also doing that through a value-based approach. And I was talking to somebody only yesterday about prudent healthcare. I'm sure everybody remembers that, and how that prudent healthcare approach is now still as important now as it was when our current First Minister launched that approach many years ago. I really would like to, as I'm here, thank you for all the hard work that you've done over recent years, but also all the things that you are now going to do to move your services on, to think about how we can respond and change, and to think about what we can do to improve the way in which we deliver care. Clearly, our system is very busy and still under huge pressure. Urgent and emergency care is an area that requires constant focus, and we know we've got a difficult winter ahead. I'm not shying away from that. But actually, we do need to keep our attention on some of the longer term issues as well. Sustainability, prevention, early intervention, population health. These are really important. If we only focus on the problems of today, we will never change for the future. And one of the things we have to do is to think about how we can accelerate some of the changes that we know we need to see, but also to think about how we can intervene early and change our services to focus on our population's health. Yes, we need to reduce waiting times at all stages of treatment. We need to make sure that people get access to care when they need it, that care is effective and efficient, and that we see the right people in the right place at the right time. But turning to bone health specifically, osteoporosis is a painful and common condition, and it probably doesn't and hasn't received the same level of attention that some of the other major health conditions have received. However, the impact on people's lives, I can testament for this, and the impact on the NHS and on social care and wider community is vast. In Wales, we have 3 hospitals which provide fracture liaison services, I'm told. They're all based in South Wales. They only cover approximately 50% of the population, and there is varying degrees of support available. I know we need to do better than that, and we need to make a consistent offer to the people of Wales so that wherever they live and wherever they need care, they can be assured of a similar standard. The model we had before is no longer an option. I know, I've seen it. I've been here a half an hour listening to some of the conversations. The enthusiasm and energy in the room is about to change. but also making sure that we're engaging with stakeholders. I think the Fracture Liaison Service will just form one part of the national clinical audits that we will need to help guide Wales going forward. And as the Minister mentioned, a really important one as well. Chris and I are giving some thought to the new NHS executive when it's set up and launched early next year. What sort of areas of quality and safety do we want to pay particular attention to? And we have a little list of audits that we want to put up as high in that priority list. And certainly I think the fracture audits will be part of that. So, but the audit data that we've got tells us we're not on our own. Yes, we know we've got things to improve, but actually these challenges exist in lots of places. And I think because of the size of Wales, we do have an opportunity to work on this together, to support each other on this journey, word I don't like, but actually be bold and ambitious in terms of what we want to do. We want a sustainable fracture liaison service, but we actually want to make sure that that pathway is there for everybody. With that in mind, we have listened to the voices that care about bone health. I think Inda's done a fantastic job to guide us to this place today. And I know that he will ensure with his energy and enthusiasm that health boards are strongly encouraged to focus on the improvements that they need to make and work alongside them as well. It is about holding to account, but actually it's about encouragement and support and actually doing the right things for our patients and their families. Of course, our goal is always to make sure that people are armed with the support and guidance they need to manage their conditions effectively. Patients are hugely important in the recovery of our services. We need to make sure they're centre stage. We need to listen to them and those who represent them. And we must make sure that when we design our services, it's designed around their needs and their feedback. Of course, self-management is a concept we hear about often. Colleagues in the chronic pain services and other areas have been championing this for many years, making sure patients are supported to manage their conditions. But it's not just about providing information. We need to support patients to understand their health, to feel that ownership and to understand their conditions. And just from my own personal experience with my dad, the time that people have taken to sit down and explain to him what's happening, what needs to happen, how it's happened, and what he can do to improve his own health is really important. Of course, we've learned through the pandemic how digital technology, how technology can help us redesign our services and support our patients better than we might have done in the past. There is a digital services for public and patients programme. There is a new NHS app in the offering. Clearly, there will be alternatives for those who are unwilling or unable to use apps. But actually, what we want to be able to do is to make sure that we can provide information to patients directly for patients to access their secondary care records, to rebook or book appointments, and to handle their interactions with clinicians. And I think across a range of services, this will be groundbreaking for us. Finally, we need to measure what's important. Chris Jones is going to talk to you shortly about the importance of quality systems, how the approaches that we're taking, not only in this area, but in every area, must be looked at through a value-based lens. We need to set out some clear ambitions. But we also need some measures to know how we're measuring against that and making sure that what we're doing is effective. So finally, from me, just want to express my sincere gratitude to Inda and everybody else who's been involved in organising today. The afternoon looks really exciting. I'm really sorry I can't stay. I really would like to sit and listen to the discussion, but there will be plenty of opportunity to share that. And I know colleagues in Welsh Government will update me in terms of the outcome of the event today. We really need to make sure that we use the strength of our collective leadership in Wales. We are a small country, but that gives us huge strengths in terms of the way in which we can work together to change the things that we need to change to. And the people of Wales deserve our best efforts in this regard. So I'd like to finish by once again thanking everybody who works in our NHS, who cares about our NHS and who works alongside our NHS. I'm really grateful for everything you do every day. Thank you so much. Diolch yn fawr iawn I chi gyd. Thank you.
Thank you, Judith. We appreciate your support and leadership and look forward to emboldening staff and help deliver the vision of the NHS we all want to see. We thank the Minister and Judith for taking time out of their very busy schedules today to attend this afternoon. Thank you. Quality should underpin all our services. As Director of Quality and Deputy Chief Medical Officer for Wales, our next speaker is uniquely placed to discuss how quality plays a key part of delivery of aims. I'd like to welcome Professor Chris Jones.
Thank you very much, Inda, and thank you everybody for letting me spend just a few minutes with some very clinical reflections on the situation we've got. I'm delighted this conference is happening. I'm really proud of the team in Welsh Government that have kind of put it all together, but also so grateful to you for your engagement and your participation in what is, I think, a really, really important agenda just at this moment in time. Now, you've heard from the Minister and also from Judith about the pressures that we know are still facing us. The pandemic hasn't gone away. There's a backlog of patients that we know need treatment, and many of them have deteriorated in the meantime. There are workforce challenges, there are challenges in primary care, but we have to get on the side of the solution. And one area where there's emerging evidence is that some of our pressures are caused by probably a lack of attention to secondary prevention in recent years. We know that following the pandemic, excess mortality in the UK across a range of different clinical conditions is still higher than it should be. And we also know from evidence around blood pressure management, diabetes management, and several other clinical pathways that the levels of effective secondary prevention are far too low, and almost certainly contributing to the events that we're seeing in our emergency units and our ambulance services. I do think fracture liaison services are now critically important, because investing in the secondary prevention of fractures in people who've already suffered an osteoporotic fracture is highly cost effective. You know, it is in an invest to save activity. It saves money, but also it will deliver a rapid return. The evidence is very strong, isn't it, that investment in prevention, secondary prevention, brings a very rapid return. So now, as part of our approach to the challenges we face, we need to invest in fracture liaison services. And I know that in Wales, we've managed to keep them going, but I know they're not adequate and not everybody is getting the secondary prevention they should get. But I think a focus on this now is really appropriate because it will help us address the challenges that we face. And it is the ultimate value-based healthcare. You know, it is relatively small investment with a very, very significant return on that investment. And the other reason why it is so important is it is a key part of the frailty pathway. And I was just talking to the Minister last week in another meeting that we were at about the challenge of frailty. Frail patients admitted to hospital, staying too long in hospital, who we know are becoming deconditioned and in the end requiring, in many cases, social care. The majority of our patients in our hospital systems at the moment are frail. So we know how difficult it is to get frail people out of hospital once they're admitted through the front door. The challenge is keeping them out. And obviously, secondary prevention to prevent osteoporotic fractures is a key plank in that. So for me, it is a vital part of our approach to the frail patient, the responsibility we have to enable them to continue to live independently with their families as they would wish to at home. Now, I also just want, I'm not going to speak for very long. I just want also to make you aware of some changes in the quality landscape that will impact on these services as well. The Quality and Engagement Act in Wales became a law in 2020 during the pandemic, but we are now implementing it with an implementation date for next April. And there are three key elements to this act. The first is a duty of candor. The second is a new, refreshed and strengthened duty of quality. And the third is the replacement of the community health councils with a citizens' voice body to cover health and social care. Now, the duty of candor is relevant to these discussions. After April, if a patient is admitted who has suffered moderate or severe harm due to a major fracture, and they had a previous fracture and did not receive secondary prevention, the duty of candor could be triggered. The health board would need to make an apology, the investigation would need to involve the family, and there may even be a cause for redress. So we need to use that legal duty now to draw attention in our organizations to the importance of delivering the care that people have a right to expect. The duty of candor is relevant to that. The other duty, which we're introducing from April the 1st, is a strengthened duty of quality, which applies to the whole system. And the duty of candor is out for consultation at the moment, and I'm hoping the duty of quality will be out for consultation either tomorrow or Monday. The minister signed it off earlier this week. So that's very exciting for us. The duty, the guidance around the duty defines quality in 6 domains following the Institute of Medicine domains. So if you consider what those are, care must be efficient, effective, timely, patient-centered, safe and equitable. Now, secondary prevention of fractures ticks all of those boxes. At the moment, we do not have an equitable distribution of care, of fracture liaison services, so we need to put that right, following the legal duty we will all be under to deliver the duty of quality. We need to provide equitable access. We know from the evidence that secondary prevention is effective. We also know it is efficient for the reasons I've described. It prevents frail people being admitted as emergencies to hospital and then unfortunately taking a long time to get out of hospital if they ever do. It also needs to be timely, but most of all, it's patient-centered. And I'm just going to finish by just reflecting on the impact of these services that you all provide on the quality of life that people can have, the difference in quality of life that effective secondary prevention can make to somebody. It is the most person-centered care. So for me, the duty of quality gives us all a commitment and a mechanism within our organizations to demand that these services that you all provide are strengthened and invested in, because we can only meet the duty of quality by providing these services effectively and consistently. So that was all I was just going to say. It's just some reflections, but I do think that for the pressures, given the pressures we face and the opportunities we have to get on the side of the solution through your services and your expertise, this is such an important agenda at this moment in time. And I hope that the changes in legislation that I'm describing will give strength to your arms within your organizations. And I should also mention that I hope the citizens' voice body will in time also strengthen the power of the public voice. The minister mentioned the need to work with patients and listen to patients as we provide these services. I hope that through the CVB, we will enable the public to become more aware of the treatments and the care that they have a right to expect. And they will start to demand, to ask questions, to understand, what care they should get and why maybe they're not getting it at times. So I do think this is a very important agenda for us all. And I'm very grateful to you for all the work you're doing in this area. This is the time to strengthen it, invest in it, and make it deliver for us all. Thank you very much.
Thank you, Professor Johns. The support shown from the government today give us all the hope that we can create services with quality at the heart. Thank you. As well as considering quality in all we do, the perspective of the patient is absolutely key. In Wales, we have adopted a productive approach involving patients all the time, and the policies are developed around their needs. The third sector and the patient voice are partners in how we do things, and no more than so our next speaker. The Royal Osteoporosis Society have been strong advocates for fracture liaison services for a very long time. And I'd like to thank Judith and the Minister for the time today. Thank you. And to discuss ending regional variations for services, we are delighted to welcome their Chief Executive, Craig Jones, to the stage. Thank you.
Hello, everybody. Good afternoon. And I'll start by just introducing the Royal Osteoporosis Society. We are the national charity for the 3.5 million people who live with the condition, and we're the patient voice for them as well. And I just want to start by, on behalf of that group of people, saying thank you. Diolch yn fawr to everybody in this room. On World Osteoporosis Day, you are the people who day after day are providing care to people who need it. And you are the people who are in the system able to tell us what needs to improve. I'd also like to thank Inda and his team. This is the most proactive gathering of officials and politicians that osteoporosis and people living with the condition have benefited from for a long time. It's more than we've seen in England, in Scotland, in Northern Ireland. This gives us real hope that we can make a big difference. I also want to thank the Minister and the team of officials there too. There has been something of a culture of passivity and defeatism when it comes to osteoporosis. We sometimes wonder why the change that we're all committed to in principle hasn't happened in practice. We have some ideas of what the reasons are. One might be that bone health sort of falls between the gaps in different specialties. It's not owned by any one clinical specialty. There's low public awareness, which leads to low demand. And also there are certain stereotypes about the symptoms of osteoporosis, which are just mistaken for just part of getting older, whereas actually, of course, they're warning signs and we can do something about that. So the first thing is to say how energizing it is to have a group like this with top-level political and officialdom endorsement in the way that we've seen just now. And what a lesson that is to the rest of the UK. It gives us enormous hope. And I do think Wales will reap dividends. This is a brief reminder. I know you know the figures, but here we are. We've got 3.5 million people living with the condition across the British Isles, 185,000 in Wales. The Minister was right. Half of women over 50 will suffer fractures due to osteoporosis, and a fifth of men. So it'll affect every other mother, every other grandmother. We see 27,000 fragility fractures, 4.5 billion to the UK-wide exchequer. And we really have to stand still with this condition, because as you know even better than I do, if we do nothing, our aging population will lead to that bill skyrocketing to almost 6 billion by just 2030. So now's the time to make a difference. And we do have those issues of deconditioning, which the Deputy Chief Medical Officer has just told us about. You know, people were at home during the pandemic, missing out on vitamin D, missing out on weight-bearing exercise. If we're not careful, the combination of an aging population plus deconditioning plus NHS backlogs will be a recipe for a serious public health crisis. And we see the results in that. Wales pays, I believe, 60 million for hip fractures every year. It would take just 3% of that amount to make sure that everybody over 50 had access to a fracture liaison service. The benefits would be felt very quickly, quicker than people think. They'd be felt in reduced need for ambulances, reduced elective care backlogs, the use of 1 million acute hospital beds across the whole UK is because of hip fractures. We could unlock a lot of that pressure by simply investing a little bit into secondary prevention, as the Deputy Chief Medical Officer said. This chart bears it out very clearly. This is about disability adjusted life years. And you can see the costs to the Welsh NHS and to the public there. You can see that heart disease is at the top, followed by dementia and lung cancer. Fragility fractures is fourth, so really near the top. And that gives a sense of the costs to society. As many people die of fracture-related causes, as from lung cancer and diabetes. So broken bones, as you know better than I do, they're no minor inconvenience. They change lives, they send people onto a downward trajectory, but we can intervene. And that's why we talk about how if we play our cards right, we can transform people's quality of life when they get older. This is one of the most serious threats to people's quality of life in later life. But despite that, there is a care gap. 2/3 of people were missing out on the care they need even before the pandemic. In Wales, that's 7,500 people who need the care that we've just talked about and are not getting it. We know that 1 in 5 people break 3 or more bones before they finally get access to a treatment plan, access to the safe, effective medications that are available, which are highly affordable for the NHS, and the falls prevention support and so on. People are getting it after many fractures in some cases, with a cumulative effect on their lives. Almost 1/3 of people with osteoporosis had to prompt their own health assessment. And we know at ROS that it's the people from lower income families who are struggling with this very serious condition, even more than the norm. Across all the metrics that we surveyed them on last year, people from lower income households were more likely to live with 5 or more fractures, to feel cut off from support, to feel their pain is unmanageable, to have to exit the labour market early, every single metric. So there is an urgent social justice argument here too. And finally, in terms of the care gap, we know that 135,000 people are living with undiagnosed spinal fractures in Wales alone, because something like 70 to 80% of those telltale fractures never come to medical attention. And of course, you all know that they are severe and painful in themselves, but they're also red flags for a future hip fracture. And imagine if we took action based on every one of those red flags, what we could do for people who need never get to that crisis point. The answers are out there. That's the optimistic, positive thing here. This isn't one of those conditions where we need to look 50 years ahead to find the tools to tackle it and make a change. There are good therapies available. And there is a great model, the Fracture Liaison service, for making sure the people who need it have access to them. It was invented in this country, in the UK, in Glasgow, and it was copied and exported across the world. So it's something of a bitter irony that across the 4 nations of the UK, there is such a postcode lottery for FLS. Wales on something like 66%, behind Scotland and Northern Ireland. We know they work, they've been exported everywhere. We know they pay back £3.28 for every pound that the system puts in. And to level up all of the FLSs across Wales to be providing support for everybody over 50, and to give you all the tools you need to intervene early and get people the help they need, would cost just around £2 million per year, 3% of that hip fracture spend. And we know the distribution already. Some health boards have a bit more provision at the moment, some behind. But underneath that, there is also a real postcode lottery for quality as well. So it's quality as well as coverage. This is a table which shows the costs and benefits for every health board. And I've sat in a few workshops today and listened to people talk about how we're not confident in all cases that we have the data to make very persuasive arguments to people who are commissioning services on the number of hip fractures preventable, the number of the returns for the system, the financial benefits over a period, and also the costs. Please come to the Royal Osteoporosis Society for that. We have it all, and we're looking for opportunities to give you those numbers to strengthen your arms in making the case. My colleagues are here today. We would love to hear from you. We will help you develop those compelling arguments. The evidence speaks for themselves, and you can get a sense of the all Wales benefits there. You can see your own health boards. It's all there. And that's not the limit of ROS's free support for people. We know that as a small charity, we can't do this job ourselves. We have around 60 staff, and similarly to the condition, we are on the small side, and perhaps not the scale you'd expect for a condition that has this level of social and economic importance to get right. So rather than try to do everything ourselves, we regard ourselves as the people who can strengthen the arms of others who are on the ground, support them, perhaps do the odd bit of pace setting and progress chasing as well, but to influence the system to improve. We have benefits calculations. We have tools that can do that. It can estimate cost savings, number of beds released. The costing pathway tool is particularly useful. ROS owns the clinical standards in this area, so we're well placed to tell you what conformity looks like. We have an implementation toolkit. We have some of the top bone health experts on our clinical committees and our boards. We'd love to put you in contact with them if you need it. And finally, patient voice. We have 20,000 members, including some of our brilliant Welsh volunteers at the back there, patient advocates who can give you that lived experience and those personal stories. And it would be a real pleasure to share that with you all and strengthen your arms in making your case. I'll just finish by saying this. What we've noticed is that there's always a competition of different disease areas, and quite often this important condition has lost out. And of course, there's now a post-COVID reshaping of the kaleidoscope, and the pieces are landing in different ways than they used to. We hope now's the time, because we think actually these arguments have never been stronger. We don't think it'll happen alone. We think a strong central mandate is needed. I think this new body announced today will be a great ingredient for success. But we hope that the modest investment can be found to bring forward some of that investment into FLSs. Think of it as priming. It'll pay back for itself within 2 years and 3 times what you put in due course. And I think what we've seen now is a great start. But I do hope that we can keep our eye on this and keep an eye on each other and what we can do to support each other in ensuring that really good intentions today finally translate into real change. I'm the first Welsh chief executive of ROS, and as a Bridgend boy, I'm particularly proud that Wales is leading the charge on this. We haven't seen this in the other 3 nations. I think Wales has a fantastic record on health innovation, from the organ donation opt-out to the smoking ban. Things have been tried here and been shown to work here, which have then been copied everywhere else. I hope this can be another example. If we get this right, we can transform people's quality of life in later life, and we can make a game-changing difference for the Welsh NHS. Thank you.
Thank you, Craig. Thank you. I strongly feel we are aligned in what we want to see, and we'll welcome working in partnership with you and ROS colleagues. So thank you again. If you are using Twitters, please do use the hashtag Bone Health in Wales to promote bone health in Wales. So thank you for that. Now, you will see from today's program that we are hearing from very wide range of clinicians, and this does include nursing colleagues, and one of our nursing colleagues is here today to talk later in the day. Now, we have got those experts from the different backgrounds, and our next guest is Dr. Alwyn Williams, representing Royal College of Physicians, to provide the Royal College perspective on bone health and how we can lead the change for bone health in Wales. Now, for some reasons, Dr. Williams is not here, but she's joining us online, and I'm sure my colleague has got all set up in the background for her, and it's good to go. Thank you. Thank you, Alwyn. We welcome you.
Good afternoon, Prawn da bawb. Hopefully you're about to see my screen getting shared. Sorry, folks, I'm having a slight technical difficulty here. There we are. Prawn da bawb. My name's Alwyn Williams, and I'm the Vice President of the Royal College of Physicians in Wales. And I've been incredibly inspired by what I'm hearing from our leaders in Wales as regards their desire for leading for change in bone health. I'm quite privileged in that I actually get to see some of the significant things that the Royal College of Physicians have done. And one of the things that we do is actually around the FSL database. So I'm going to actually focus a little bit on some of the statistics. And first of all, you know, we have heard some major issues around our bone health and fractures. So here we are. This is what it looked like in 2020. Just over 4,000 hip fractures, you know, just under over 1,250,000 fractures, but significantly 5% of these individuals were dead at 30 days, and 25.6% of those individuals actually never returned to their own home. And that is quite depressing. But also what we've seen is actually that the refracture situation is pretty dire as well. And this is where we can really make a difference. So what can we do? Now, many people have talked about prevention, and certainly the Royal College of Physicians are very much into the social determinants of health and health inequalities. And what we've actually seen due to the pandemic, that we're more likely to see more individuals come forward with osteoporosis. So there is two-pronged approach here, is actually partly around ensuring that those people whose diets are going to be probably decimated through poverty, the fact that some people will turn to more alcohol because their poor mental health as a result of what's happened in the pandemic, and also to look at the fact that people did possibly do less exercise over the last 2 years, but also being aware that some new medication, access to HRT, people, young women using the depot injection and the use of PrEP in men who have sex with men to prevent HIV infection could also impact what we have going forward. But really what today is about secondary prevention, about detection and intervention, and making sure that actually those people who've already got osteoporosis get the best care that they need. So really, it's about output and outcomes of intervention. And one thing around what we have in Wales is the fact that the National Falls, Fragility and Fracture Audit Programs. These are hosted by the Royal College of Physicians, and you can see that there are 3 main databases: the National Hip Fracture Database, the National Audit of Inpatient Falls, the Fracture Liaison Service Database. And probably it should be Dr. Johansson that's giving this talk rather than me, but I'm going to just go look forward around what is happening with the Fracture Liaison Service Database. Now, the FLSDB collects from 77 fracture liaison services across the UK on patients over the age of 50 who've sustained a fragility fracture to measure the quality of secondary fracture prevention. And the database includes around 550,000 individuals a year. The database aims to evaluate patterns of assessment and treatment for osteoporosis and falls across primary and secondary care. So this gives us real quality and granularity of data. But actually, when we look at what's happening in Wales, we can see that we really probably only have 3 main areas collecting data, and that those areas are actually not really achieving the over 80% data collection, and only around 50% at the moment. So there is a significant amount of work to do. And I think this is one of the things from today, and the leadership we'll see from Inda and the team is going to be really quite important going forward to make sure that we get this data collected so we know what we need to do. If we look at the 3 areas that's actually in the database at the moment, it's Aneurin Bevan, Morrison and Llandoch. And in 2020, there were only 2,033 records submitted, and that's across the national average of just under 73,000. So again, we can see across those KPIs that some were in the green, but the majority were in the red. So we really need to just get on and get it done, but also spread it across the health boards in Wales. We've heard about what having a fracture liaison service might cost. The fracture liaison service have looked at this with the Royal Osteoporosis Society, and this looks at the data. So there are approximately this many individuals living in Wales at the moment who are over 50. There are just under 29,000 fragility factors per year. Now, if there was an FLS identifying 80% of those cases over a 5-year period, 4,389 fractures would be prevented. That would mean that there were less surgeries, less acute beds, and less costs. So, you know, that would be hugely impressive. So let's look at what it would cost to have those services across Wales. It would actually only be £1.98 million across Wales per annum, and that would have a huge impact on individuals. This would be looking at appointing 20.4 whole-time nurses, 13 admin staff, and having £25 database per local site. I think that's probably 1,000, 5k recurring. So the cost, so the investment needed to actually save such a distressing condition is minimal. And we're really, really hopeful that with the leadership that we're seeing at the moment from the top and from India and the network, this will achieve this. So it's a fixable problem. Please, you know, that's a bit of a pun. Fracture liaison services are a must do. So we do then, as a college, really value the fact that leadership, and leadership can, one doesn't have to have a title to be a leader. And remember that our nurses, everyone who's involved in this service should really be leading. And we've heard from the Osteoporosis Society around patient involvement. Patients can be leaders, carers can be leaders, they can influence, they can actually make change happen. I am a strong believer in activism as a patient and as a patient advocate. The establishment of the Fracture Liaison Service Development and Quality Assurance Group is a huge step forward, and we hope that we can support that. But there are other things that we also need to support, and that's actually in training and service development. We are aware that there has been some investment in the FFAP QI collective collaboratives, working with IHI, and making sure that our consultant colleagues working in these fields are really, you know, understand the quality improvement that they need to do to actually ensure these services are set up. We also need to look at new ways of working, taking care closer to home, making sure that our outpatient services can be virtual. But also, we also need to look at who is actually delivering some of these services, who's running the DEXA scanning services, who's working within care of the elderly, who's actually delivering services within primary care, who's actually got responsibility for primary prevention and the secondary prevention. And also, we really need to make sure that everyone is aware of some of the very, very niche things that they can do personally. I've got a confession. I did my own FRAX scoring, and I recognised that actually one thing that I need to do would be actually ensure that my alcohol intake was moderated. Now, I'm not sure many people know that that's an impact, but those are the sorts of messages we need to get out there to ensure people are aware of what the primary prevention of osteoporosis. And I'm just going to finish by actually putting up some of the resources that we have on our website in the RCP for patients and their families. So we have information around you know, what would happen if you are or someone that you know experiences a fragility factor, the six golden rules video resource, stronger bones after 50, fracture liaison services explained, and the bone health card. So I do think that putting patients in the centre of this and our population in the centre is the best way forward. Thank you very much for letting me speak this afternoon.
Thanks you, Alvin, and I hope you're feeling better.
Thank you.
Now, Wales have an aging population and we must adapt accordingly. And this is to ensure that populations age successfully and age healthy. Now, our next speaker is Dr. Sam Ibrahim. Sam is representing British Geriatric Society and providing reflection on how we collectively can make an NHS fit for older people. Thank you, Sam.
Good afternoon, everyone. Thank you, Vinder, and the organizers for this excellent meeting today to highlight the importance of prevention of osteoporosis. I'm extremely delighted. I was here in Swansea a couple of weeks back for the British Geriatric Society autumn meeting. And then on 30th of September, we were attending the European Geriatric Medicine Society meeting at Excel Centre in London. We are going through a turbulent times, and I think I'm just not mentioning the political picture, but our NHS is really facing a crisis period in this time. I think before I start, I just want to say that these are all my own views rather than not fully the views of British Geriatric Society. If you look into the tabloids today, you can see everyday news is that NHS in a crisis. And I think it's a difficult paradigm to understand the pressures facing clinicians across the hospitals in Wales and UK. Who is to blame for this? I think, you know, it is not a blame thing. We are actually caused this because of the developments in science and technology. And we can see that the demands on healthcare has increased over time. Just look at this graph there. You know, the life expectancy of people have increased. By 2030, we would expect the average life expectancy to have gone up significantly. So, you know, people would have expected to live till 91 for females and 88 years for males as an average. And this will create increasing health needs. So the rising demand has created this increasing demand for services. I think it is also mingled with the availability of new treatment, not only for osteoporosis, you know, for all other conditions, cancer treatments. So services are fighting with each other, and the new investigations like scanning, MRIs, thrombolysis for stroke are putting increasing pressures on our services. And one of the main factors people may highlight is that the number of availability of inpatient beds have gone down over the years. This graph is very interesting. We can see that the number of beds per 1,000 population in UK is actually one of the lowest in Europe, second only to Spain. But this in itself is not a bad thing. This is probably a result of our British way or European way of efficient working, or the new modern way of efficient working. We have advanced in science and technology and realized that we don't need so many inpatient beds. But in the economics of scale, it's difficult to extrapolate, you know, where is the correct balance. So we need to look at newer ways of working to meet the demands of the society we live in. So British Geriatric Society, if you look at the website, you can see more is done, more advice is there available to health boards to create newer ways of working. One of the areas we want to promote is the discharge to assess services. I think this is one of the key areas where people can work together to get a reduction in length of stay so that people can get the therapy needs they need closer to home and reduce the length of stay. And these are really important measures so that the front door pressures in the hospitals are reduced. I would just bring an example of one of the measures we did in North Wales in Wrexham was creation of the discharge to assess model there. And I was really skeptical about such a model last year. But I think over the last year, we looked at the data, it has shown that the efficiency of the service has resulted in such a cost saving about £1 million, so that it was able to pay for the cost of salary of the of the staff involved in the service. I'm sure such preventative measures will benefit us all in the future. So BGS also wants to highlight our document on ambitions of change for improvement of care of people who live in care homes. This is an area where a lot of preventive medicine can be practiced. And as such, most of the people in care homes are at high risk of osteoporosis and falls. So it's important that we provide education and training to carers and clinicians working in these areas. Although I've been blaming the pressure on the NHS, it's not such a bad story. NHS is actually a success story. We can see that the health-related mortality rate has come down over the years. From 1991 to 2021, you can see the standardized mortality rate is actually come down. So we are not doing a very bad job. To quote from Winston Churchill, success is not final, failure is not final, it's the courage to continue that matters. So I'm hoping that every one of you here will continue to strive to improve the services. What does a good health service look like? It's difficult to define. I've just quoted this from Kingsford paper from David Oliver about 7-8 years ago, and I think it still holds true. Everybody wants a wholesome health service that will allow us all to age well, remain well, add an active life, and get the much needed acute services when we need it, and a person-centered care, as well as support, control, and choice at the end of life. The economics of provision of such services is difficult at times because of the varying demands on various services. Cardiologists will say that they want more money into cardiology services. Rheumatologists will say they want more money into rheumatology services. So it's often difficult for health boards to determine which service is more beneficial for people. I think what one would want to do is reduce your disability at the end of life or towards the end of life, or improve your healthy lifespan. The disability-free life expectancy in the UK was 63 years for males and 61 years for females from 2017 to 2019. Actually, there was a significant decrease in the healthy life expectancy for women by 1 year during this period. If you look at the statistics again, it was because the men caught up with the healthy life period. People aged 65 and more have a 30% more chance of falling at least once a year. And of these, 50% of the fallers will have a hip fracture or other fracture. On the 30th of September, as I was attending the European Geriatric Medicine Society meeting, the World Guideline on Falls was being published. And then we heard about how few of the vertebral fractures in men and women are being picked up. An audit across the radiology services in the UK showed that 50% of the fracture of the spine are missed on radiology reports. This is not a deliberate thing, because I think what the authors explained was this was missed because it was not looked into or asked for by the requesting team, or even if mentioned in the radiology reports, this was not picked up as important by those interpreting these results. So I'm really impressed that the Welsh government is supporting the fracture liaison service rollout on this auspicious World Osteoporosis Day. As all been said in the last speech, we need strong leadership, not only at political level, but also at regional levels, at local hospital levels, and people who are really stakeholders of this. So I'm grateful for Inder's leadership in this, and the Royal Osteoporosis Society to support as clinicians in setting up such services. And I hope that this will be a success for Wales. Thank you all very much. Diolch yn fawr.
Thank you, Sam.
One of the problems with today being World Osteoporosis Day is that it started about 15 hours ago in Melbourne, where I was lecturing overnight. It's been going on a very long time. We've brought down the government during the course of the meeting, so we better let you out to have your tea. The most important questions you're all going to want to ask will be to Craig and to the team from the ROS about how they support you in writing the business cases for the fracture liaison service that's been demonstrated to be useful. So why don't we have a break now, and can we get back in here by 3:15 for the final session? Thank you.
Thank you all.